Good afternoon, everyone. My name is Giosa. I'm a professor in the School of Nursing and director of the Institute for Healthy Living and Chronic Disease Prevention here at UBC Okanagan's campus. Before we begin this afternoon, I'd like to respectfully acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. And I also want to acknowledge that some of you might be joining us from other places, both near and far, and take a moment to acknowledge those traditional owners and caretakers of those lands as well. It's a beautiful day, afternoon, in the Okanagan, and I'm really appreciative of being able to live and work in this space here today. So I'd like to welcome you to the 10th annual Okanagan Embrace Aging Month. And of course, thank you for joining us today. Embrace Aging is hosted by the Institute for Healthy Living and Chronic Disease Prevention here at UBC, and also Interior Savings and Credit Union and Interior Health. Also, UBC Okanagan has joined the Global Network of Age-Friendly Universities, formalizing its pledge to make UBCO more accessible, intergenerational, and committed to research programs that are informed by the needs of an aging society. If you want to know more about our Age-Friendly University initiative, or have suggestions for us, or would like to get involved, please contact the Aging in Place Research Cluster, and you can reach them by aging.inplace, all one word, at ubc.ca. They also have a website, and if you Google Aging in Place at UBC, you'll find it. So to let you know that Embrace Aging was launched 10 years ago to celebrate and raise awareness about positive aging. And once again, we've organized a number of educational opportunities events throughout the month of March. As some of you may know who have joined some of our other events, these sessions are designed for everyone, both young and old alike, and have focused on a variety of topics related to healthy aging and ways to improve quality of life among older adults, family caregivers, and others. Our goal continues to be to inspire everyone to embrace positive aging. So before we begin our webinar today, just a few housekeeping things. You might find a closed captioning box on your screen. And of course, you can move it around to a preferred place by dragging it, or you can close it off by using the hide caption button on your menu bar. In terms of questions and comments on the presentation, we invite those at any time into the chat box. And towards the end of the presentation, we'll read out those comments and questions and have a discussion. So please don't hesitate to use the chat box. So today's event is brought to you with the support of the Embrace Aging Planning Committee and partners. And I'm really delighted to welcome Nelly Oelke and Justine Giosa to our presentation today. Nelly Oelke is an associate professor here at UBC Okanagan in the School of Nursing. And Justine Giosa is scientific director of the SE Research Center and an adjunct professor at the University of Waterloo. So I'm going to turn it over to them and welcome to Embrace Aging, Justine and Nelly.
Thank you, Joan, for that great introduction. And Justine and I are certainly very happy to be here. So we'll get into our presentation and have opportunity for questions at the end. So I first too want to acknowledge that UBC Okanagan and myself, that I'm joining you today from the traditional unceded territory of the Syilx, the Okanagan people. I'm actually located in West Kelowna, and I'm just going to turn it over to Justine for a moment to acknowledge, do a land acknowledgement as well.
Yes, thanks, Nelly. I'm thrilled to be here. And the University of Waterloo also acknowledges that much of our work takes place on the traditional territory of the Neutral, Anishinaabe, and Haudenosaunee peoples. And our main campus is situated on the Haldeman Tract, the land granted to the Six Nations that includes 6 miles on each side of the Grand River. And our active work towards reconciliation takes place across our campuses through research, learning, teaching, and community building, and is coordinated with our Office of Indigenous Relations.
Thanks. So we also want to acknowledge our team members. This is not a small team, not Justine and I, but rather a larger national team with participation from Nova Scotia, as well as obviously Ontario is where the project is being led, and then BC as well. And mostly I want to acknowledge that we have a large working group of about 31 participants that are participating as experts by experience. And so this is a very participatory approach project, and includes the lived experience of people who are engaged in this work, in work around mental health for aging. So our presentation is going to look at some background around aging and mental health, specifically what don't we know yet, looking at the participatory research to action framework, and then identifying research priorities. We're also going to review the purpose and aim of this research project specifically, review the 3 phases, focus specifically on phase 1, and provide some preliminary findings. And then we also want to talk about how you can get involved in BC, or if you're elsewhere in Canada and joining us, through a survey, and then possible collaboration opportunities as well. And I am going to turn it over to Justine.
Thanks, Nelly. So I'm really pleased to be able to provide some background and context for the project that we're going to be focusing in on today, and really starting with some aging and mental health knowledge gaps and some sort of just setting the context for our conversation today. So when we talk about mental health, and I think this really aligns with Joan's comments at the beginning around embracing aging, we really think about our positive sense of well-being, or the capacity to enjoy life and deal with the challenges we face. And we really situate our dialogue around mental health and aging using the Canadian Mental Health Association's 2 continuum model, which you can see here on the slide. So we're trying to move away from this binary concept of mental health, thinking about mental health as either mental wellness or mental illness, and really thinking and separating out sort of diagnoses related to mental health from mental well-being. So as you can see in the 2 continuum model, it's really possible to have a mental health condition or diagnosis and still experience well-being. And similarly, it's possible to not have a mental health diagnosis, but experience poor mental well-being. And so we really want to think about that and how that impacts sort of the aging experience. And there's knowledge that age-related changes can impact our overall mental health. So things listed here on the slide, these are just a few things, but there's others as well. Loss of social roles, retirement, bereavement, physical and cognitive changes can really impact overall mental health. But on the whole, there is really a limited amount of aging-focused mental health research really diving into the interplay between these age-related changes and this 2 continuum model. So that was our starting point for starting to think about aging and mental health. And so in the SE Research Center, which is where I work primarily, in addition to my work with the University of Waterloo, we are an impact-oriented health services research center. And what that means is we are situated within the broader context of a learning health system and a healthcare organization where we have access and have interactions with system end users. So older adults, clients, and their family caregivers, as well as health and social care providers. And so our commitment as an action-oriented research center is to ensure that we're taking a participatory approach, as Nelly mentioned, to all of the research that we embark on. And that means engaging experts by experience right from the beginning in terms of identifying the gaps and problems that we want to address, all the way through to co-designing solutions and then implementing and evaluating those solutions together. And so you'll see that this is sort of the guiding framework behind this mental health and aging research project that we're going to be speaking about today. So in thinking about those mental health, aging and mental health knowledge gaps that I just mentioned, we were thinking about how could we actually approach this? How do we understand what we should focus on? And of course, we wanted to consult aging Canadians around what their priorities were for addressing this aging and mental health knowledge gap. So before the pandemic, which seems like a long time ago now, we set out in collaboration with the Canadian Mental Health Association to consult with aging Canadians through a priority setting approach. And so we had 2 national surveys where we asked older adults, caregivers, and health and social care providers what they wanted to know about aging and mental health. What were their burning questions that they would hope to have some researchers address? And then through literature review, as well as some interactive workshops, we were able to identify some of those questions that had some preliminary answers in the current literature, and then prioritize the remaining unanswered questions into a list of top 10. On the slide here, you see some screenshots of some of our interactive workshops that took place through this process. We had planned for those to be in person. However, with the pandemic, we were able to adapt those to an online format. And one really nice thing about that was it allowed aging Canadians coast to coast to connect with one another on this topic. And it turned out to be a happy accident as a result of the pandemic. So 2 of the questions that we really honed in on in thinking about the next steps in our work was the top unanswered question that was identified, which is how can healthcare providers who are not mental health specialists build their skills for providing mental health care to older adults? And specifically in these workshops, there was a lot of dialogue around personal support workers or healthcare aides, unregulated providers working in home and community care, usually in sort of a physical interaction with clients. How could we upskill or sort of support them to participate in mental health care further? And then certainly on sort of some questions that had answers, one that stood out to us was, are there user-friendly tools available to help people identify signs of positive or poor mental health in themselves or others? And in a moment, I'll speak to you about something we found in our search of the literature called the Mental Health Continuum model. So diving in a little bit deeper into these 2 sort of questions, this first one around how can we build skills in providers who are not mental health specialists, but who are interacting with the aging population in a routine way? Why is this question emerging as a top priority? Some thoughts we had about this is that systemic ageism and negative mental health attitudes are certainly barriers to seeking needed mental health support, care, and treatment. And aging Canadians also experience those stigmas, sometimes in a dual way. So both those stigmas together. Onset of the COVID-19 pandemic has certainly made it more difficult for older adults to seek mental health support. And we also know that 30% of older Canadians' current mental health is worse compared to pre-pandemic. So that also reinforces the need to build capacity to address this growing challenge in our system. We also know our publicly funded healthcare, this is province to province, tends to focus on identifying and responding to physical healthcare needs. And this can lead to missed opportunities for intentional conversations about mental health between providers and older patients during routine care interactions. And so this could lead to misdiagnosis or things going underreported that should be addressed. And so we were thinking, how can we start with these conversations? How can we start promoting more conversations in these existing care interactions? The other question around, are there user-friendly tools to help people identify signs of positive or poor mental health? In our initial search of current knowledge and evidence, we came across a model called the Mental Health Continuum model. And some of you may be familiar with this. However, for those who aren't, this is a model that was developed by the Department of National Defence and the Canadian Armed Forces and is used in their Road to Mental Readiness training. And it's really meant to destigmatize the concept of mental health along that continuum, as I mentioned earlier, and really help for people to reflect on the different components of mental health that maybe they are experiencing. And so this model has been used in the context, like I said, with the Canadian Armed Forces, first responders. It's also been adapted and used with university students. However, to our knowledge, there was no use or application of this model in the home and community care space with older Canadians. And so we thought, could we do something here and think about this question in combination with skilling up providers to address this growing gap in aging and mental health. So I will end the background there and hand it back to Nelly to talk about how all of that background comes together into our current project.
Great, thanks, Justine. So then getting back to co-designing action-oriented mental health conversations, the goal of this project is to co-create and test an evidence-based approach to mental health conversations between older adults, caregivers, and health and social care providers. And we're looking both in rural and urban settings, and we're looking at community care, so home and community care settings across Canada. And our grant is supported by CIHR funding. So just to reiterate again, the participatory nature of the project is that we definitely, we'll show you exactly where we've engaged again, but that this came from the initial conversations and priority questions and working through that. So we have different folks involved across the province or across the country. And you can see by that we have, researchers in different provinces. We have collaborators in different provinces. And I just want to point out in BC, so I am the co-investigator that is leading the BC work and working together with a research assistant that we just hired, Adrian Peak. If you talk to us, certainly you'll be talking to Adrian as well. And we have a rural location that has been confirmed. We're working together with the Princeton Community Health Table, and we will be doing phase 2, phase 3 in the Princeton Karameas area. We're still looking for a urban area in Kelowna or perhaps Penticton, Vernon. If you know of an organization that would like to get involved, we'd be happy to hear about that. So phase 1 looks at exploring the use of the mental health continuum model with older adults in home and community care. And so from September through until late last fall, we did workshops, online workshops with older adults, caregivers, as well as then care providers across Canada. And so we engaged, I think we had, it's in the next slide exactly what we're going to be doing or what we did. And then we're also working with an online survey. So we had a total of 59 participants in the online workshops. We did workshop 1 with older adults. Workshop 2 was with caregivers, and then workshop 3 was with care providers. And then workshop 4 was with a mixed perspective. And the intent originally was to also run French language workshops, but there did not seem to be, we certainly didn't receive a lot of participants who wanted to participate that way. And so then we ended up doing some one-on-one interviews. So this is a list of sort of the characteristics of the participants who were engaged in the workshops. So you can see that the majority of people that did engage were women. We had a fair range of both older adults and caregivers. These are informal caregivers. Care providers, we did have a lot less participate. And you can see that most of the participants were from Ontario and age varied with regards to what ages folks were. So this is just a bit of information on, we worked through a scenario. And it was the Hannah story, which was about Hannah, the son who is the caregiver, as well as then a care aide And so using that fictional story, using the continuum model, and then looking at how that might need to be changed in order to address the needs of these various perspectives. So I am going to hand it back over to Justine to talk about the changes around the continuum model that were recommended by the participants.
Yeah, thanks, Nelly. So in the workshops, as Nelly mentioned, we really were working with that fictional story, and that story we co-designed with our working group members, which was really useful in making sure that it represented the lived experience of the older adults and caregivers and providers who've been working with us since the outset of the project. And we really wanted to illuminate some of the different elements of the mental health continuum model and provoke some conversation around some of these different elements. So in our first activity, we were really focusing in on the things that you see highlighted here on the continuum model. So getting the input of participants on these levels across the top here, from healthy to ill, 4 levels, and the color spectrum from green to red, as well as the 6 categories along the left-hand side. So mood, attitude and performance, sleep, physical symptoms, social behavior, and alcohol and gambling. And those are meant to sort of represent the multi-component thinking around mental health as sort of a complex, dynamic context. So that was our first activity. Our second activity then focused in on the sort of the real content of the mental health continuum model, which we chose to describe as signs and signals. So the things in these different categories that would help to place someone's perspective of where they are along that continuum in terms of these 6 categories. So we were asking participants, again, using that case study narrative, to provide input and ideas around which pieces did resonate with thinking about adapting this model to the context of aging and home and community care, and then which elements didn't resonate or perhaps needed to be changed or added to make this more useful in this context. So I'll spend some time talking a little bit. Obviously, that is a lot of data for 3-hour workshops with almost 60 participants. We had a lot of data to analyze, which was really wonderful. And they were very engaged sessions, full participation. We had 100% turnout to all of these workshops. So they were well attended, but certainly we were able to roll up the comments to these 5 bullets here. So when we were thinking about how the mental health continuum model could be adapted to support mental health conversations with aging Canadians in home and community care, participants really wanted us to consider improving the use of action-oriented language across the model to align with sort of what would happen following a conversation about mental health. They were hoping that we could think and consider about the more inclusive use of color in the model. They wanted us to think more deeply about capturing the element of change over time and thinking about mental health as a dynamic concept and moving back and forth along the continuum. They were really concerned about the use of clinical jargon and diagnostic or potentially stigmatizing labels or language within the model, and so really pointed out opportunities to improve that as well. And then certainly they requested that we revise as well as add details to the signs and signals to be more aging context relevant. And so they were quite helpful in thinking about the different signs and signals that we may want to consider that would help with prompting conversations about aging and mental health in home and community care. So the output from our workshop analysis was the mental health continuum model for aging Canadians. And you can see that it looks quite a bit different than it did originally, based on all of the input that we had from our participants. And because we recognize that this is a lot for a single slide, a lot of content to be covering in a single slide, what I'm going to do is break it up into different sections and talk about some of the changes with reference to some of those overall findings that I mentioned just a slide ago. So starting with the categories on the left. So you'll recall that there were 6 original categories and we ended up with 6 still. However, the participants really felt like some changes needed to be made to sort of meet the needs within the context that we were looking at. So I won't go through all of the different changes that were made, but I can certainly highlight a few. So you'll recall there was mood, attitude and performance, sleep, physical symptoms, social behavior, and alcohol and gambling to start. And one of the most significant changes, or I guess one of the most biggest areas of discussion in the workshops was really around the category of alcohol and gambling. There was a feeling that this was very narrow, very limiting, and very stigmatizing in thinking about how people might choose to participate in these types of things, and wanted us to broaden the language around that to habits and coping strategies more generally, to think about how people may engage in different things from both a positive and negative perspective. So that was one of the major changes that certainly was reached consensus very quickly with participants around needing to broaden that category to be less stigmatizing and more inclusive, and thinking about how some of these things may be actually helpful to people in terms of their coping strategies for mental health and wellness. Another thing that people really focused in on, oh, sorry, Nelly, I'll just quickly go back to that last one there. Yeah, another thing that people really focused in on was the attitude and performance category in the original model. So they felt like that very much resonated with sort of the Canadian Armed Forces lens on mental health, and perhaps, really understood why that was sort of a necessary category in that context. But in sort of an aging context, particularly thinking about home and community care, there was a feeling that we needed to shift our thinking towards the experience of daily routine and activities, and really focus in on not sort of attitude and performance around these, but sort of, completion of daily routine and activities and things that may ebb and flow around that in someone's day-to-day life. So those are two examples of changes to the categories and sort of rationale for those changes as a result of the input of participants. So in terms of the action levels and talking about change over time, so at the bottom here, you see the original sort of 4 levels that I mentioned earlier, labeled from healthy all the way to ill. And at the top here, you see the revised action level wording. And so this is what I was speaking about before, with participants requesting more action-oriented language to help sort of understand how one might follow up after a conversation about mental health. And they felt that the categories or labels in the original levels were also a bit too diagnostic and a bit too labeling for a tool that was meant not to be a diagnostic tool, and that was confusing. So instead of healthy, reacting, injured, and ill, participants suggested all good, take notice, find support, and seek care. And then gave us some suggestions about wording around what the actual action might be following sort of a conversation that landed them in one of these particular levels. You'll see the bidirectional arrow is still present in the adapted model. However, participants were really hoping that there could be a little more guidance in helping people situate themselves across the continuum with some guiding questions. So we ended up having, has there been a change since from usual? Has that change become a pattern? So it's not just a one-off change. And is the pattern causing anyone concern? So there was a lot of reference to things such as anger, for example. You may be angry, once or twice, and sometimes anger is a positive reaction to things. However, it's maybe not necessarily a change from usual, but if it is that becoming a pattern? And is that angry pattern then becoming a concern? So that's just one example to provide and why we added those questions to the bidirectional arrow. In terms of the use of color, I'm just looking, is the next slide. Yeah. There we go. I can see it now. Thanks, Nelly. Might have been delayed on my end. So folks were a little concerned about the use of colors that were previously existing in the model. They felt like it really did resonate with sort of a Western societal perspective on sort of a stoplight approach. So there was recognition that, green, yellow, orange, red really kind of aligned with a stoplight approach, but there was concern that maybe these colors weren't culturally inclusive or culturally relevant. And from an ED&I perspective, we needed to consider, the use of color in a more inclusive way. And so what was suggested was the use of color blue. That was suggested across all of our different workshops. And it came up as a suggested color resonating with different things in different cultures in terms of strength, calm, peace, etc. And to this date, and I stand to be corrected if anyone has additional input on the color blue, we have yet to find sort of any negative connotation with the color blue in this context, and there seems to be, good support for moving to that use of the color blue. So instead of using different colors, the suggestion from participants was to have a gradation or a gradient showing sort of progression across the continuum versus moving from a green to a stoplight red. In terms of the signs and signals, this is where we had a lot of detailed input, so much detailed input that this is actually a summary and actually whittled down quite a bit from, or rolled up quite a bit from all of the detailed input that we had. So participants really felt that if this mental health continuum model for aging Canadians was going to be useful in the context of guiding conversations between providers, older adults and caregivers in home and community, that more examples, and particularly examples of the gradation of these things across the levels, would be needed to be available for reference in terms of helping to situate those conversations in an action-oriented way. So you'll see that there's quite a few examples in each of the categories, particularly like I had mentioned earlier in the habits and coping strategies. There was emphasis on sort of moving away from considering just alcohol and gambling to thinking about medication use, tobacco, food, and other engagement in hobbies and activities like shopping, collecting, exercise, social media, etc. So just being a bit more inclusive and thinking about those types of things. So I'll pass it over to you now, Nelly, to talk a little bit about what we're doing now in terms of our public consultation through our survey.
Thanks, Justine. So the second step or the second component of phase one is an online survey of a larger group of the same perspective. So again, older adults, caregivers and care providers. And we're looking for about 1,000 people. And I'm happy to say that we are well above 500. Again, Ontario has the highest number of responses, but BC is number 2. And so we've done some great work in recruiting participants here, but we'd be very happy for anyone to complete the survey to provide further feedback on the adapted continuum model. So here then is the QR code, and we're also going to have the link for the survey put into the chat, so you'll have that as well. And again, anyone who's over 55 and over can participate. Anyone who is a family, friend, caregiver, so an informal caregiver to an older adult can also participate. And then we are definitely looking for health and social care providers that work in home and community care to participate, because that is currently our lowest participation. The survey will close on the 6th of April. And participants can enter a draw to win one of 10 $50 gift cards as well. And we'll put up that QR code again in a moment. So phase 2 is to actually co-design mental health conversations within existing care interactions. So this is where we are going to work with an organization, or we're going to partner and work together with an organization. And so we will hold a in-person 5-hour workshop in 6 rural and urban sites across the 3 provinces, so 2 each. And what we're really looking at is very site-specific but general implementation processes for using the mental health continuum model, the adapted one, to engage in mental health conversations during care interactions. So what would health and social care providers that work in the community think about how this might be implemented? And then phase 3 is really looking at feasibility and pilot testing in likely each of those same organizations and communities. And so that will take, phase 2 is going to happen. It's starting to be organized, will run through the end of this year. And then phase 3 will run from February to September of next year. So this is the end of our presentation. Happy to answer any questions about our presentation, as well as participating from a BC perspective. And my email is there, as well as Olinda's, who is the project coordinator for the national project. And I just references, and I'm going to go back to the QR code. Or Joan, do you want me to stop sharing?
No, this is fine. I think that's great. The links have also been put in the chat, just so that you know. And I see you've got an email address here too, so people, if they want to, can also reach out through the email. I'm interested in what that survey looks like and how long it takes to finish or complete. I'm sure some people are also thinking that.
I can certainly speak to that. So in the survey, the survey itself takes about 15 minutes start to finish that we've heard on average. And that includes watching a brief video at the beginning that will overview much of what I shared today with regards to the model. And then we're asking for people to provide some of their input around those different elements of the model. So really what we're hoping to do here is engage these perspectives in a broader way from our workshops and understand sort of whether or not this adapted model resonates with their own experiences, and whether or not there's any tweaks or additions or changes we may want to make before we use this model as the basis for phase 2 and phase 3. So we're just really trying to finish off that adaptation in phase 1 and make sure that we've consulted a broad number of diverse Canadians on this particular model before we take it as our evidence base in our co-design sessions.
Yeah, that's very helpful. That gives me a much better idea. And I'm assuming they're questions with options for answers, and so that it can be completed fairly quickly. Is that the case?
Yes, so everything's scaled on a Likert scale, sort of 1 to 5 type of approach. And then there is an opportunity for an open text box response at the end, asking a couple of additional questions if you'd like to provide further comment as well.
Oh, that's great. That's very helpful. And so I can understand why you'd be looking for feedback and people to complete this survey to give you the kind of information you need, that you're looking for a very diverse group. So I'm wondering if there's people that in particular you're looking for, older adults, over the age of X, people from different kinds of communities. Do you have a sense of what you still need for this survey?
Yes, I think Nelly alluded to a couple of things that we're looking for. Certainly, we've already done a better job in terms of diversifying our response from our workshops, which was very Ontario-centric, for example. I think we have a better proportion of men who have participated in the survey so far, and certainly representation from a geography perspective of more geographies across our country. But certainly we have all of these materials are available in French as well. So we are able to hopefully have more Francophone Canadians participate in the survey as well. So that is available if anybody is interested in circulating some of these materials in French. But as Nelly mentioned, we're really looking to have more health and social care providers working in this space participate in the survey. I think as you may anticipate, some people hold multiple perspectives. So we do have some people who have participated in the survey who are both older adults and caregivers and health and social care providers, or one or more of those perspectives. But certainly, I think our lowest perspective represented in our current respondents are those health and social care providers. So if we can improve that, that would be great. And then I think there's, a variety of other factors that we're looking at from a diversity perspective in terms of race and ethnicity and cultural diversity. And so we're looking to kind of spread and share this opportunity to participate in this survey to people's professional and personal networks as far and wide as we can. So anyone on the webinar today, we'd certainly appreciate not only considering participating in this survey if you hold one of these perspectives, but certainly we have materials that we can share with you following the webinar today that you can circulate those to your networks and try and help us spread the word.
Great, yes, absolutely. We can do that. And actually someone asked in the chat if the slides would be available, and I think what they're referring to is the new and revised framework that you've come up with, where they can have a closer look at it. And I know by participating in the survey, there'll be an opportunity to do that for sure. Are we sharing the slides afterwards as well?
We certainly can. I have no issue with sharing those out for folks to have a copy of. No problem.
Yeah. And of course, if people online joining us today can help distribute this invitation to complete the survey, we welcome that as well. I am really impressed with the suggestions that you got from your workshops and how much different the tool looks now, and just really amazed at the value of really speaking to and gathering expertise from people who probably have the most to gain, both older adults, but also caregivers and people working in this space from using this tool. And so I'm wondering if you can talk a little bit about those conversations and how they unfolded, and what you learned about doing conversations with these particular people and knowledge users.
Yeah, absolutely. I think, I'll speak broadly and then I'll go specifically to the workshops, but taking that sort of participatory, we call it the participatory research to action approach. And really what it does is sort of blend a traditional sort of integrated knowledge translation perspective from a health services research lens with sort of a service design thinking, co-design kind of lens. And it really brings together sort of being open and flexible and adaptable at the beginning of a project, where sometimes as health services research, we like to be very specific around sort of our questions and the gaps and the aims that we have, but really being open to collaborating on those with people who are living and breathing this every day, and ensuring that the project is guided by those people who are experiencing the gaps and the issues firsthand. And then certainly really prioritizing co-creation of solutions. And that's where these types of workshops come into play. And it really is about, we are really used to having sort of verbal dialogue with people in research, where we have interviews or focus groups, where we're collecting sort of verbal input from people. What we're less comfortable with, and this is where the service design sort of element comes into it, is pushing people to think beyond sort of just verbal feedback to really creating things or co-creating things, and really thinking about making things beyond just talking about them. And so when we use things like case study narratives and personas and ask people to participate in activities where they're not just providing feedback, but they're really trying to immerse themselves in the story of somebody else, use empathy to guide sort of their perspectives around how we might change or adapt something, you end up getting just a lot more fruitful conversation and ideas around what needs to be changed. And what we find then is, after these solutions are co-created, the solutions end up being more realistic, they end up being more feasible. And when we move to that action part of the framework and implementation and evaluation, there ends up being more acceptability of the outputs. And then certainly the potential for impact is greater. So it is a lot of upfront commitment and dedication to that partnership approach. And it is, fairly time intensive. And preparing for these workshops took certainly a lot of time beyond, and you saw our large team. So beyond just Nelly and myself, there was a lot of work that went into planning and partnering and building rapport with these participants, even before the workshop, emailing with them, providing them with workshop packages, phoning them and making sure they felt comfortable and had sort of everything they needed to fully participate in the sessions. And then lots of follow-up afterwards as well, and ensuring that they are carried through the whole project, ensuring that they have an opportunity to continue to add their input throughout. So it is a lot of work, but certainly we find that it ends up being more fruitful in terms of the output. And that's sort of why I think we were able to get such detailed input and suggested changes to the model to be context relevant to what we were trying to explore in home and community care.
I think one of the things that will be interesting is how we move, well, first of all, to get feedback, in the survey, but when we move forward into the phase 2 piece and thinking about, so how do we implement this? And, when we look at it, we think, oh my gosh, there's so much detail and so much there. Is it going to be feasible? And how do we work together and co-create ways of actually implementing this in a way that's going to work for health and social care providers?
Yeah, this is really a fabulous example of what value community partners and regular people out there in the community can contribute to ongoing projects, research projects like this, and why we need everyone's participation in these projects and how important it can be. So a really lovely example of that for sure. And for any of our audience who are thinking about getting involved in research, this is a lovely example of the value of people's contribution for sure. And any ideas about how you will, so you're getting this data from the survey and you'll get some ideas of whether any further changes, I guess, might be needed to the framework. And then begin to share it in your next phase about trying to figure out how it can be, what form it should take, I guess, and how it can be implemented. Is that the case?
Yeah, absolutely. So I think what we recognize right now is we have, it is what it is. It is an adapted mental health continuum model. And, a model in and of itself isn't applicable in any way. It's a model. And so how might this model be used in routine home and community care interactions to support conversations around mental health is sort of our question for our next step. So even in our initial, and participants were so keen in our initial workshops, we would have the conversation sort of veer off into this sort of realm where they were starting to think already, oh, this could be a pocket guide. Oh, this could be a magnet on the fridge. This could be something we turn into a little booklet, and they were giving lots of ideas about how you would take a model, sort of this concept that we have here and turn it into an actual tool or resource or something that could be applied within the context that they're used to working or receiving care in. And so we're really interested and keen to partner with community organizations in rural and urban settings in these 3 provinces. And our goal is to really build on their existing care interactions. So many times when we try to do co-design, we're trying to do something net new, and then we have to figure out how to work it into their existing practices. But what we're trying to do is figure out how do we take what they're already doing and build on top of that and fit it into their existing care routines so that it's something complementary to what they're already doing. And different organizations already have good strategies in place for some of these things and perhaps need help in other places. So it will be really interesting to see, what's similar across all of these different sites, what's different and unique, maybe from a rural urban lens, but also just from a provincial. As you know, provincially, we have different healthcare systems. And certainly then be able to move to a pilot and feasibility testing that meets the needs of the individual communities, but also thinks about, scale and spread, and how might we take the things that are common across all of these places and think about how that could be used more broadly across our country. So that's our hope and our plan. I think right now, we're really keen to find those organizations, in particularly for today in BC, that are really keen to explore this with us and also test it out. So it's not just phase 2 and co-designing the solution, but really then working with us to action it and see if it's working and it meets not just the needs of the research project, but certainly really want to focus if it meets the needs of their organization. And so, wanting to make sure that we're doing this in a really good partnership way. So for anyone who does have connections to those types of organizations in sort of the Kelowna region, Penticton region, certainly open to hearing from you. And certainly we have lots of resources and tools to support good partnership, everything from honoraria and compensation considerations for providers participating to how we would actually conduct the sessions and being very flexible in that way.
Yeah, that's great. And so Nelly, the kind of organizations you're looking for are those that provide services to older adults. Is that it? Do you have some examples of other kind of community partners that you have in other regions to give us a sense of the kind of organizations you're looking for?
Great. For instance, so we're looking for any health or social care organizations, and they could be nurses, LPNs, or also care aides or formal caregivers. For instance, in Princeton and Karameas, we're looking at working with Princeton Family Services Society that has an outreach worker, that sort of thing. And also the organization that deals with housing and seniors housing. So another type of an organization that is providing services and actually engaging with older adults. It could be Interior Health and their care aides and RNs, LPNs as well.
Mm-hmm. Great. Well, this is very, very helpful. We do have a comment from Claire saying this is amazing work. Thank you. And I couldn't agree with her more. Very amazing. It's really wonderful to hear about this and to think about. Even I'm starting to think about, okay, how could it be implemented? And I think about it sometimes just as even a self-care tool that people might have to kind of empower them to sort of monitor. I think we're all sort of monitor our health from a day-to-day basis, but I think, as you already mentioned, we tend to focus on the physical health in terms of how we're feeling physically. But this might be a very helpful kind of cue to action. I'm trying to figure out how you get it on my Apple Watch. So instead of just counting steps, I might be trying to see where I am in the shades of blue.
Oh, that's great. Yeah, it's a great example. We certainly have heard similar comments around, other potential uses of this sort of model that would complement or sort of be sort of, complementary to the conversations that we're trying to evoke, and maybe be sort of follow-up activities that have a conversation and then keep this on your fridge and refer back to it, for example, or on your Apple Watch. We'll have to engage some app developers or something for that, beyond my expertise. But certainly, yes, we've had lots of people thinking or visioning those types of ideas. So we're so excited to get into the co-design phase following this survey and really dig into those ideas and see what we can make happen.
Yeah. Well, this has been really a wonderful conversation to hear about this research. And I do want to thank you both for joining us and sharing this with us today. It's been it's amazing work. We were just talking about participatory research with my class this week. This is like an ideal example. I'll have them watch the video, I think, because this has been really, really interesting and a great model for others for sure, in terms of participation, co-design, and this multi-stage project to get to implementation and wider dissemination and uptake. So really lovely. So I do want to thank you both for sharing this research today. And I also want to thank everyone who joined us today. And there are a few more sessions left before the end of the month. So if people have a chance to jump into those, by all means. And if you want to see what we have coming up over the next few days, you can go to OkanaganEmbraceAging.com to get more information about those events. And also any that you missed, you'll be able to find on our YouTube channel as well. So thank you once again for this brilliant presentation and for joining us today, and wish everyone a great afternoon. Thanks so much. Bye for now.
Thanks.
Thank you.